Thank you very much. Good morning, everybody, and welcome to this board meeting of Herefordshire and Worcestershire Health and Care NHS Trust. For those that don't know me and those that perhaps may be watching on YouTube, my name is Mark Yates. I chair the board. Can I do some welcomes first? Can I welcome all our guests? And I know we've got some relatively new trade union officials joining us. You're very welcome indeed, and I know that you have good engagement with members of the executive team. And should there be anything that comes up today afterwards, if you wish to, ask anything about it, I'm sure any of the executives will be available to you as normal. We have some other guests with us, and they'll become apparent as and when the agenda gets there. But a couple of announcements before I move on. Firstly, there'll be a slight change in the running order today. Only slight change. That we're going to take the patient's story straight after welcomes and inductions, and before we do the general housekeeping of minutes, and we'll come to that in a moment. But some other announcements. Janet, Vice Chair, has been reappointed for 2 years, so thank you for wanting to do so, Janet, and congratulations on getting through the NHSE hurdles to do so, because I know it is a bureaucratic difficulty. I know that Jill does, so I'm personally delighted. I'm sure the board's delighted to have you along for at least another 2 years. Thank you.
Thank you very much.
Biraj Palmer, who can't be with us today because he's on NHS induction down in London with some other colleagues. He has been appointed to full NED status, I think, from August the 1st, and so Biraj is replacing the irreplaceable almost Steve Peake and on F&P chair. The other announcement I was going to make is Jamie. Jamie, this is your last public board meeting. Jamie Morris, who's been with us. I think Jamie and I sat together the other day. We thought, should we say somewhere between 6 and 8 years? Neither of us could quite work it out. We got 7, is it? So that's between 6 and 8. So I'll go with that. Jamie's been a non-executive director for 7 years within the trust, and he retires from the trust, having completed his stint on the 6th of November. So this will be his last board meeting. Jamie has been a stalwart and has brought a huge amount of experience into the trust, notably from local government, where he was in senior positions, I think in Walsall and Birmingham from memory, but certainly I think maybe Walsall was his last appointment. But he also brings a wealth of experience from other activities that he carries out. And as I said to him the other day when we were having a chat, Jamie is always to be relied upon by this board to ask the difficult questions on occasions when they're not so easy to ask. And for that, I think we're actually going to miss you, Jamie. I know we've got another 6 weeks to go and a variety of meetings you will be attending, but this is the last public board meeting. So I wanted to, at this moment, thank you for your service, and certainly when you finish with us, to wish you well in all else that you do. And as I know that you told me the other day, you're busy regardless of the NHS. So thank you very much indeed.
Thanks, Mark. May I just say very briefly? I'll try and think of I will try and think of challenging questions this morning to continue the tradition. But I did want to say what a great privilege it's been being on the trust for the last 7 years. I've enjoyed it hugely, working with some brilliant people doing fantastic work, and I would like to take this public opportunity to wish everyone on the trust all the best wishes for the future to continue the brilliant work you all do.
Thank you, Jamie. Okay, well now, as I said, we'll quickly reorder the agenda, and we'll move to the patient story. Before I do move to Natalie, I do wish to, I suppose, declare our patient this morning I do know, in that Jane and I are schoolgate acquaintances, I suppose is the way to describe it, because both our children went to the same primary school. Although I've not talked to Jane at all about whatever she's to say this morning, because Natalie and her team have been liaising, so I have no idea what is to be said. But I am aware of the broad outline of the story because I'm aware of the family. So I thought everybody should know that before we start. Natalie.
Thank you, Mark. So just welcome to Jane, who's going to speak through her and her husband Kevin's experiences. Unfortunately, Kevin can't be with us this morning, but Jane, I know we have his full consent to talk through his journey from your perspective. And I know Dan Marshall, who's the matron for the hospital Kevin was in, was hoping to join us, and I can just see he's here. So any questions regarding the care, we have Dan with us as well. So I'll hand over to you, Jane, if that's okay. Oh, have we lost Jane?
It does look so.
Oh dear, we knew she was having some technical challenges this morning. I thought she was with us.
She was a second ago, Natalie, or when we started, and she had sound and vision as well, so that was sorted out. But we'll just give a second or two as she comes back, and then if that is not to be the case, Dan, you are likely to be stepping up to perhaps illuminate some of the story, I guess, between you and Natalie. You may be on the spot if Jane can't join us, which I'm sure won't faze you at all, Dan, from my knowledge of you.
Shall I give some context and hope that Jane joins us
yes,
for a while? So Jane's husband, Kevin, experienced a significant stroke. So his care started in our acute partner hospital, and he was then referred and transferred to Evesham Hospital for his stroke rehabilitation care. When I met with Kevin and Jane, they spoke in a lot of detail. Jane speaks, Kevin's still having significant challenges with communication. So he's able to process information really well, but what he wanted us to know today was he wouldn't be able to verbally communicate a huge amount with us, because that's one of his functions he's still struggling with and having ongoing care through our stroke community team. But they spoke to me about how the care at Evesham really saw them as a family, and his recovery journey was so personalised that it was all about him. And that sounds really simple and basic, but they spoke about how important that was. Jane particularly speaks around how included she was in that care, and how their daughter was as well. So welcome of visiting times, staff spoke to them all really compassionately about their experiences and what the future would look like potentially, given that, as Jane would describe, that their journey's got an unknown ending, so they don't quite know how much functioning Kevin will ever recover, and so they don't really know what life will look like. And as for a considerably younger man, that comes with a whole set of challenges and difficulties as well. So Dan, I don't know if you want to describe a little bit about the care you deliver at Evesham on the wards and stroke rehab. I think that'd probably be helpful.
Yeah, so we're actually here commissioned for 32 beds, but we've run significantly over 40 for the last year or so. We take direct referrals from the acute stroke unit. They come over to us probably a little bit earlier than they did previously. So they come subacute care, so some of them are quite unwell when they come across. What we have done, which I think has improved things over this last year, is increase the amount of therapy we have here. So we have a large therapy team that helps very much with the rehabilitation of patients here. We have also rejigged our staff in here, nursing staff in here. So we have a band 7 and a band 6 over all the wards. That again has improved communication and care. I think, to be honest, I hear nothing but good stories that come from the patients and the families that come in. We have an open door policy. If anyone's got any issues or any problems, I do ask them to come and speak to me. And I just think we offer a very, very good holistic care here at the moment. And yeah, I don't know what else to say, really. Things go very, very well here, and it's the feedback I'm getting over this last year has been exemplary.
Hello, Jane. You back with us?
Hi, I've moved. I'm on mobile now.
Oh, okay. Just to say, I will hand you over to Natalie in a second, but Natalie and Dan have just sort of outlined that Kevin is a stroke patient. But yeah. Natalie, I don't know if you wish to introduce Jane as to where we've got to.
Hi, Jane. Welcome. The joys of technology, we were saying. So brilliant. Dan was just outlining kind of what Evesham Hospital's commissioned for, and I was just explaining that you and I had met, and you talked me through some of your experiences. But I'm going to hand over to you then, if that's okay, and if you'd like to share with us kind of your and Kevin's experiences of our care.
Okay, brilliant. So yeah, obviously had a stroke 10 months ago now, and obviously through acute care. After that, we obviously came to Evesham for rehabilitation. Brilliant is just the first word I want to say. Yeah, it was a surreal experience at the time, almost like an out-of-body experience. But for me anyway, but they were just amazing. The welcome was second to none. Anything I wanted to ask, when I wanted to ask it, it didn't matter. You know, nobody ever once said to me, "I'll be with you in a minute, I haven't got time," or, you know, that usual thing of where you're left wondering what's going on. That there was always someone there to answer questions. The care that he got was absolutely amazing, from all angles, not just the nursing team, but, you know, the doctors obviously, but the healthcare assistants were just fantastic. They got him to do a lot of occupational therapy, above and beyond really that they had time for, but they pushed as far as they could. They get him to try and do painting and drawing and things like that. Yeah, it was incredible to see how the team at Evesham cope in the environment, which isn't that great for them, obviously. We were in IZOD ward, which of course wasn't actually designed to be a stroke ward initially, but I gathered due to COVID rules and things like that at the time, you had to use the access of a separate ward to spread the patients evenly away from each other. So that ward itself was not really ideal, but it didn't hamper anything that they were trying to do for Kevin. It was just incredible, really. He wouldn't be as far down the line as he is without that much input at the beginning. Yeah, they were brilliant. I don't know whether
Thank you.
Sorry.
I was going to say, thanks, Jane. I think the easiest thing to do, I think there's a number of colleagues on the screen who've probably got questions for you, and I think that would then illuminate the process that you've been through. So if I do them as I see on the screen, so we'll start with Janet. If you could introduce yourself, because obviously Jane doesn't know who you are, Janet, and then we'll go to Tessa.
Yeah, thank you very much, Mark. Yeah, hello, Jane. I'm one of the non-exec directors, and I chair the Quality and Safety Committee. And I have to say, it's so delightful to hear a story where actually we've delivered care that you've described in such glowing terms, and particularly because I was sitting thinking, goodness, Evesham is the one where we really worry about the environment, and I think you've demonstrated that actually the team pulling together can almost overcome the drawbacks of the environment, which is really, really impressive, I guess. So I suppose my question is actually, what do you think makes the care so outstanding? You know, because the team is made out of individuals. So how, from your perspective, do you think they work as a team? And what learning can we take from that? Because we like to think that all our teams work like that, but realistically, I suspect that probably isn't the case. So what learning can we take from that and spread to our other teams? Because we want your experience to be everybody's experience, so that we're not sitting here saying this is amazing, this is just what we deliver.
Yeah. Yeah, they work so cohesively with each other. You almost, you know, you are told when you come in, this person wearing this colour does this and this person does this. But as I say, there was always never a problem with the crossover in terms of if you had a specific question, that whoever was around would be able to say, well, as far as I'm aware, it's not what I do, but you know, this is my past experience. They would tell you what had happened before, or what they could possibly do going forward. It was very hard to distinguish who was, you know, actually doing what. So it was a real team effort completely. They were giving each other feedback continually. You know, you never just saw physio today, OT tomorrow, or, you know, there was a cohesive working environment, and you found that the experts in their particular area, so physiotherapy, for instance, obviously they would take patients up to what they call the gym, and do things up there. But they would come back, they would immediately get the feedback from the auxiliaries on the ward saying, you know, how's he been? How was he after yesterday's session? Was he tired? Do you think I'm doing it at the right time? Shall we move it a bit? There was always that sort of working together partnership between the different professionals on there, which made life a lot easier for us, because everyone knew what everyone else was trying to achieve and do. And they were quite, you know, they would have meetings about that, you know, and go through individual cases. You felt like no one was coming in cold. Oh, well, I don't know anything about your case, which is what you get on acute. You know, you do get that sort of disjointed, that's their job, this is our job. Evesham was completely refreshing from that point of view.
Thank you. I mean, I think what you're describing is really around communication and openness, isn't it? And I think that's excellent. Thank you very much.
No problem.
Hi, Jane. I'm Tessa Norris, another of the non-executive directors, and I chair the workforce committee for the trust. And it's really great to hear about the teamwork and the way the team work together genuinely and share the responsibility of care. I'm interested around what you said about the environment not being ideal, because we know as a board that the estate at Evesham is not ideal. But I just wondered, given, you know, that yourself and your husband and your daughter had a very difficult diagnosis of stroke, and Natalie said that your daughter had felt welcomed to the ward. I just wondered if there was anything that you could suggest to make the experience of visiting a subacute rehab ward more accessible and more comfortable for children, because I think we often forget that there are children in families. Yeah. We deal with a lot of frail elderly and older visitors, but I'm curious about the experience from a child's point of view, really.
That's a really good angle, Tessa, I think, to come in on for stroke wards per se, you know, not just Evesham, but all of them. Yeah, there is that. We found this. I mean, people are completely floored how someone as young as Kevin can have a stroke. But then you start to realise, actually, you can have a stroke as a child, you can have a stroke through any age, which I think is never really promoted enough. And like you say, trying to explain what has happened to a child to their father is extremely difficult. And as far as I'm aware, there was nowhere or no information at any time. It's actually something, thinking about it, you could take forward to the Stroke Association as well, is how to explain to a child what is going on and how the stroke is going to impact your parent or your, you know, any member of your family, really. So yes, I think actually, you know, that is a really good point. Maybe there would be a more, I think there was not that I ever used it, actually. I think there was a patient's ring, like a family ring somewhere. But we didn't really feel we needed that as such as adults, I think. But maybe there should be a zone where the children can have their experience with their patient, their stroke sufferer, their parent, away from the main section of the ward. That would actually be a really good idea. You know, a sort of little enclosed space somewhere that could be more comfortable, you know, more like a lounge, I suppose, more like a home environment. That would probably ease it a little bit for them. Yeah, she was so welcome, though. She was, you know, involved. They were quite happy for her to sort of push him a bit later on, but to push him down to the restaurant and back, and were quite happy to involve her in discussions. And there was one event where on one visit it was snowing, and it was more snow your end than our end, and they sort of invited her to go outside Kevin's window from where his bed was to build snowmen and throw snowballs at the window. You know, so, and she was allowed to do a bit of artwork with him when she was there and things like that. So yeah, it is a really valid point. You tend to forget that younger stroke victims have a younger family. Yeah.
Thank you, Jane.
Good idea.
Jamie.
Thanks. Thank you very much, Jane, for sharing your experience. It was, like Janice and Tessa said, very, very good to hear the good work that was put in by the team, and as far as possible, working as closely as possible for you and your family's benefit. The question's more for Dan, actually. That Dan, I wanted to know what are the kind of obstacles or challenges that you face in ensuring that all the stroke rehab patients' experience is as good as Jane and her families can be, as exemplary as it can be. I mean, I'm making the assumption that if we were to talk to the families of other patients, they wouldn't all say the same, have the same kind of experience as Jane. Some may have been quite different in some ways. And I just wondered, you as the manager, how do you try and ensure that consistency of approach, and what makes it that difficult for you?
We have communication across the hospital is really good. I have regular meetings with the 7s, 6s. I'm a very visible matron as well, so I'm out and about on the wards. I speak to patients, I speak to families. I've got an open door policy here. I've always had that at the hospital to ensure that if families have got any issues or any problems, they can come directly to me. You know, not everyone's experience will be brilliant, because obviously sometimes if they start the journey, as everyone knows, start the journey poor in the acute, that journey tends to be bumpy all the way along. But the communication here, it has improved over the last couple of years. We have an open door policy. We encourage people to come and speak to us. I think at one time it was very easy if anyone had an issue to say, you know, go to PALS and go that route. What we say now is come and see the matron, go and see the band 7. So we try and resolve any issues or any problems at source. And I think that's improved, you know, patients and families' experience here, rather than waiting, you know, a long time to get a response. So the message I give out to my staff is, got any issues, you can't deal with it, push it up the line to me and I'll speak to the families, and I'm always available. But it's about the visibility as well. It's visibility of senior staff around that people can come and speak to.
Thanks, Dan.
Thank you. Thanks.
There's nobody else showing, but Jane, I do have one question, if I may.
Yes,
and I appreciate last time I saw you, we were standing in an aisle in Aldi about 4 or 5 months ago, and Kevin was still at Evesham.
Yes.
But my question relates to the transition from our services at Evesham to the community teams. So what was that transition like? Did you have the required information to know what was to happen, one, before you went, so before Kevin was discharged, and then what has it been like having the community stroke team? So I'm just interested in that. The reason I ask is very often in the NHS, not ourselves, but across the NHS, there can be gaps between, call it, episodes of care, and I'm interested in how that transition happened.
Yeah, that's a really good point. Absolutely flawless coming from Evesham into the community stroke team. They were absolutely amazing. We knew exactly what was going to happen. You know, we were told who even it would be, because obviously some of the physiotherapists I'm aware of, there's one in particular that transitions between being on the ward with you for 6 months and then out on community team for 6 months and back again, which she absolutely loves working that way. I'm sure Dan knows who I'm on about, and was absolutely superb. I mean, she was fantastic because she knew exactly what type of program that he would have been on in Evesham, and therefore it made it much more fluid to pick it up once you got home. The OT was fabulous. She came to the house, assessed everything. The equipment was here ready. We didn't have to wait for that. I've heard of people from, you know, other parts of the country. I've actually got friends that have had a stroke up in Lancashire at the moment, and they're saying it's very disjointed. You know, they're not getting that fluid transition period. The only time we've had a break where we've had to wait was after the 6 weeks of the community stroke team, ending and being picked up by the acquired brain injury unit. So we did have a big gap there. That's only actually just started to kick in the last couple of weeks, Mark. But they are fabulous. Now we've got them, they're brilliant, exactly the same. But there was a gap there. But we were able to cope in that gap because of the knowledge that I've been given by everyone at the hospital and again into the community stroke team. I felt that the two teams were definitely of the same, there was no disjointed communication at all.
Thank you. That's good to hear, because I think we have got a newly formed community stroke team, or they're doing things slightly differently, because I did visit them, I can remember. But Dan, are you going to illuminate us a bit on this?
Yeah, we work really closely with the community stroke team. My staff, particularly the band 5s, rotate around from acute stroke into Evesham into the community. So yeah, they know the business very, very well. So they're all familiar with each other. They all work together. So although we don't always get it right, it should be a seamless journey for a patient from here into the community. And you are right, at the moment, Mark, we are bolstering up the community teams in order to try and take people home earlier from here. So that's work in progress at the moment. But it's good to hear that everything was in place, because sometimes equipment is really hard to get hold of, and I have to do a lot of chasing with equipment. But again, if we've got issues with equipment, I tend to put the emails out to equipment stores to try and get things a bit earlier, so we've got stuff going out to patients. But I'm really pleased to hear that the transition was good.
Okay, thank you, Dan. And okay then, Jane, thank you ever so much for coming along today to share your experience. I know that it's a very personal experience to a family when you go through such a long period. I think you said Kevin's stroke was 10 months ago.
Yeah.
But one of the main reasons, there's two reasons we ask patients to come along, is so we can hear directly from the patient or the patient's family, and two is to pick the learning. And as you've seen today, I think there's a couple of learning points that have come up, which is great. And I know that Natalie and the team will follow that up, because we're always interested in trying to make things better. I think I speak on behalf of the board in saying, one, thank you, and two, we wish you and Kevin, and I know Amber, all the best in the continuing recovery. I know Kevin's had a recent setback. We hope that is overcome really quickly. And thank you ever so much for joining us, Jane.
Yeah, I'll just he's just on the way down the stairs now, so I'll just let him say hello. Hello.
Okay.
There's Mark and everyone from.
Oh, hello.
Hello, Kevin.
Hi, Kevin.
Good to see you. Good to see you on your feet. And Jane's just done a brilliant job of explaining your journey and some of the learning we can pick up for people that have been through a similar process to yourself. So it's great to see you on your feet again, Kevin. And thank you ever so much.
No problem. No problem at all, Mark. I look forward to seeing you in Aldi again.
Yeah. Okay then. Bye now. Thank you very much indeed.
Bye.
Dan, did you just wish to conclude there?
Yes, thank you very much. It's good to have that really, really good feedback here for the hospital, and I'll feed that back to the staff on IZOD, because they've had a bit of a rough ride on IZOD. It's good to see that we've got really good stories coming from that ward. And if it's okay with the rest of you, is it okay if I go?
Yes, I know you've probably got other things to do, shall we say, Dan? So, but thank you ever so much for joining us and adding to the value that we can get from the patient story that came through your part of our world.
Thank you very much. Have a good day.
Okay.
Bye.
Thank you. Thank you, Natalie. If we can move on to some brief housekeeping now before we move forward with the agenda. So, the apologies for today are our 4 newer non-executive directors: Birch Palmer, Sue Hinks, Vina Allison and Carol Mino. They're all on an NHS provider non-executive director induction in London, which is unfortunate timing for today, but they were willing to forgo that. But I suggested that they're so few and far between in London as a face-to-face that they would actually be better off attending that. So they've got good justification for not being with us. And we've also had apologies from Lisa Yates, who's unable to be with us for personal reasons today. Okay, the minutes of the meeting held on the 20th of July. Does anybody have any matters of accuracy or matters arising from those minutes at all? Nope. Thank you very much again, Jill, Sharon. Thank you very much for the accuracy and the quality of the recording of that meeting. Fantastic. Thank you very much. Which moves us then on to the action log. The actions are all closed, but Jill, is there anything to say about any of those actions at all?
No, unless anybody's got any questions that they'd like further information about.
Okay. No, nobody's showing. So again, thank you very much. They're closed off, which is always good to see. We now move to questions from members of the public, and we do have a question from the member of the public. So I'll move to Jill initially, who I think has the question.
Yes, so we've got a question about how seriously does the Trust take family voice for mentally unwell patients? I understand Sue's going to answer. We do have the requester on the call as well, and I will follow up the response in writing after the meeting. But Sue, do you want to pick up?
Yes, thank you, Jill. So the Trust has two current key policy strategy documents that outline the organisation's approach to hearing and responding to the voice of patients and carers. These are our engagement strategy, which sets out a framework for working with people and communities, and our carers policy. Both of these documents have been shaped around the organisation's long-standing commitment to implementing a strategic approach to co-production. This was signed off in a Trust board in 2015 and refreshed again in 2018. Our strategic approach recognises the expertise and knowledge of all of its stakeholders, and staff strive to work from a basis of equality and to listen. The Trust has sought since 2015 to ensure these core principles of co-production are explicit in all of our policies and strategies, with a focus on embedding these principles most importantly into the delivery of care to our patients and their carers. And we've further enhanced this through the commitment to trauma-informed care and approaches and through compassionate care. These core principles have also evolved into personalised care, where our focus is very much on shared decision-making with patients and carers. And to this end, the Trust has supported a rollout of staff training to help embed good practice in this regard. The Trust also recognises that carers are an essential and knowledgeable source of expertise and hence a crucial part of the delivery of health and social care. And it was this recognition that led to the Trust engaging in building health partnerships a few years back, where we worked closely with our local carer associations in both counties to find out how we could better work with carers to identify, support and involve them. This led to some very practical actions around carer passports and enhanced training for all of our staff. The engagement strategy, which emplaced the 2018 strategic approach, was approved earlier this year, and it outlines the involvement in carers and family. It's recognised by the Trust as crucial, and that challenges cannot be tackled without drawing on the diverse thinking of those who know the issues best: local people, staff, parents, their families and carers, and those who represent various groups in our community. The Trust recognition of the particular needs of carers, though, has seen the development of the carers policy, which has been in existence for some years. This policy is currently being refreshed in light of the fact the Trust now works with carers in Herefordshire as well as Worcestershire. The new document has been slightly delayed because we're waiting for the refreshed Herefordshire carers strategy so that this can be reflected in our Trust document. However, the basic approach to carers will remain unchanged, and it's based on the triangle of care, which acts as a framework for the document and outlines the importance of identification, involvement and support. Finally, though, some very recent work to ensure the support and involvement of carers and family is the prepared carer checklist, which emerged from national and local services surveys indicating carers and family needs at discharge. So as we've just heard in the patient story, it's making sure that carers are involved in discharge and are aware of the changes that may well happen at the point when their loved one returns home. So in the Trust, we're progressing this through various channels with the aim of embedding it into inpatient services, both physical and mental health, over the upcoming months. However, it's important to say that more work has to continue around the carers agenda. We need to raise awareness so that where consent is given, we can be assured that family and carer involvement is always happening to the right level. To this end, our work with local carers associations is crucial to better understand the needs of carers and family members, and they will be central to the refresh of the carers policy. And with this response, we'll also attach our engagement strategy and the 2018 strategic approach to co-production to give that context and history, as well as some of the links to carer support and getting involved that are on our Trust website.
Thank you, Sue. Sinead, thank you for your question. Firstly, we really appreciate you taking the time and trouble to send a question in, because we as a board always welcome engagement with patients and patients' representatives, as you've seen from this morning. And we always have a patient story at board. Some are, shall we say, positive and uplifting, like the one this morning, and other times it's actually the opposite end of the scale, when we listen to some quite difficult stories about how we've not done as well as perhaps we should have for patients. I do notice in the chat box, the chief nurse Natalie has volunteered to come and meet you, and discuss with you in more detail and face to face, I suspect, which I think is probably more beneficial than a written response. You will get a written response, obviously, but I think Natalie coming to meet you should be a real step forward in allowing you to express your views and maybe your frustrations, so we can pick up any learning that we have, if that's okay with you, Sinead.
Yes, I would welcome that. I've been waiting 3 years to get to this point where someone will actually listen, so I would very much welcome that. Thank you, Natalie.
Okay, I'm sorry it's taken this long, Sinead, and the fact that you've come forward today, but and that's something perhaps will be part of Natalie's investigations as to why it's taken this long. But certainly Natalie will engage with you. And Natalie, if you could please report back to board at some stage about the findings and what we need to change or do differently in relation to that, I'd appreciate that. Thank you ever so much, Sinead, for coming along today. Your interest, your question will inform our sort of improvements going forward, and that's all we ask. So thank you very much indeed. Okay, folks, thank you, Natalie, and thank you for the answer, Sue. Comprehensive answer, and I know that Jill will ensure that is sent out to Sinead. Declarations of interest is the next item, and we know that they should all be on the website, and if anything changes, I always remind everybody to make sure they're forwarded to Jill as soon as possible, which then takes us along to item, which is the Chief Executive Report. Sarah.
Thank you. As usual, my report covers a range of national system and trust issues, so I'll run through them. There are quite a few key issues in there, though, that I need to draw out for your attention. So firstly, starting in the national sphere, I've mentioned the fit and proper person test for board members, which board members will be aware that nationally NHS England have issued a new framework around fit and proper. It's outlined in my report with the key issues. It will mean some changes to things like appraisal systems and how we retain references. It also affects what sort of checks are done on appointment of board members, and also on exit. So on exit, a reference is required for every board member that leaves, in quite a lot of detail, actually, having looked at the template. So Jill is working through with Mark what we need to do and what needs to change to comply with the new framework, and more of that in due course. I've mentioned the Lucy Letby trial. As you know, Lucy Letby was convicted of appalling crimes towards young babies and children. And everybody in the NHS, I think, has been really shocked by her actions. And it really rocks staff, as you know, because staff come into the NHS to really care for patients and work tirelessly to support their patients. And incidents of this nature are a real shock. Our thoughts are definitely with the families concerned. You'll know that NHS England have written to us as a board and asked us to do some specific actions, which I've put in my report on page 5 or page 42 on diligence. So it clearly says there what board actions are required. A number of them relate to Freedom to Speak Up. So we need to make sure they're carried through into Quality and Safety Committee and Workforce Committee in terms of monitoring that the actions have been put in place. But hopefully you've all had a chance to look at that. It's to do with staff being aware of how to speak up. It's making sure we're referring to the National Speaking Up Support Scheme, although Natasha, who I think is on the call, was mentioning to me that there is some issues around referral to that process. So obviously we need to look at that. and make sure it's clear how staff can access us if they wish to, and also about how we proactively need to reach out to staff who have cultural barriers to speak up or who may be in lower band roles and less confident to do so. And I think that point in particular is something we need to work harder on. I think we know that our facility staff, for example, tend to work part-time hours, tend to be on lower bands, tend to have less access to some of the networks to support. So I think there's some specific work that we need to follow through there. And that board need to seek assurance that staff feel they are confidently speaking up. And as you know from our last discussion with Natasha, boards will receive regular reports from Natasha as our Freedom to Speak Up guardian, and will be shared. The available data will be shared. So just to really draw to your attention, because there's some very specific actions board are asked to take there. And I guess just to confirm that we are fully committed from our we've had previous conversations about this, and as a board I know that we are fully committed to developing an open culture and making sure staff feel they can speak up where that is required and necessary in a range of ways that they're comfortable with. So a real priority for us as a board. In terms of the Lucy Letby trial, I'm sure we'll hear more detail in the coming months, and there will be more things that are of note in terms of learning that we need to reflect on. But at the moment, it's those specific actions for board we've been asked to address. Moving on to page 6, you'll see reference to the operational resilience request, particularly around planning for winter. I'm sure that'll be picked up in the operational report later on, but we are very aware of these 4 areas of focus that we've been asked to look at in our resilience planning. And just to say that the system and both places have done a lot of cross-organisation working around planning for winter. I've touched on COVID and flu preparations. We're now starting to get into vaccine season. There have been some issues around supply, but primary care colleagues are now receiving a regular supply of vaccines, and we are definitely in the process of training our flu champions ready to start the flu vaccines internally as well. So that's all moving forward. On page 7, didn't think I'd be talking about concrete, but I have just put a reference to reinforced aerated autoclaved concrete rack. You'll know from the press there's been a real focus on this type of concrete in schools and the implications for the school estate. So just to give the board some assurance that based on our current investigations, we do not have any significant issues of the use of rack within our buildings. However, the new NHS guidance that has been received in the last few weeks actually suggests a slightly different and more detailed approach to testing our position. So Mark Fenton, Associate Director of Estates and Facilities, is leading this work, and we will be doing some more testing of our estate. So if anything else comes to light, we'll bring it back to board. I've referenced the Workforce Disability Equality Standard report in my report, but it is also covered through the Workforce Committee actions, and the report in full is attached to our papers later on. There's reference there to the new NHS enforcement guidance. And I particularly wanted to draw out on page 9 the new NHSE Sexual Safety Charter. So there is a new National Sexual Safety Charter, which it sets out 10 pledges, including commitments to provide staff with clear reporting mechanisms and support. So it's aimed at staff and patients, and I know we've already had a significant focus on the charter in terms of patients, and some work underway in that regard. Natalie's bringing this through our governance processes, so we will come back to it in due course. My note in my report asks us to sign up in principle to moving this forward, so I would appreciate people's commitment, but it will come through in more detail in due course. Also, just of note, it was discussed at the ICB board yesterday, and ICB partners signed off and supported it yesterday. So just to note that. On the bottom of page 10, really important document, the new National Suicide Prevention Strategy. The NHS, the Mental Health Collaborative, executive group are looking at this in more detail at our next meeting next week. But important strategy. I've circulated a summary of the document already to board members, and it will come through our suicide prevention group in the trust and through Equality and Safety if there are further actions highlighted we need to address. In terms of system issues, I've mentioned industrial action, but Matthew will pick that up later when he gets to the operational report. And I've also picked up, just to note, that Stephen Coleman has been appointed as the Managing Director for Worcestershire Acute Hospitals NHS Trust. Stephen's known to many of us as he used to work in this trust as our Chief Operating Officer. So I'm delighted that he's coming back to the Worcestershire system and will be very prominent in the leadership team moving forward, which I think will be really positive for our partnerships. In terms of specific issues, you'll know internally we've had a real focus on the CQC. We had our well-led visit, which started with service visits in February, culminated in a well-led inspection in June. Just to note for the board, we're still waiting for the draft report, which we haven't received yet. But as you know, we've had emerging feedback raised with us by the CQC on a range of themes that were in my board report last time, but include issues around making sure we have an open culture, having more of a focus on EDI and race equality, and looking at our approaches to managing risk. So there's a lot of work going on. Scott Parker has joined the team. I'm delighted to say the ICB have supported Scott coming on secondment to the organisation as our improvement director. Scott is working full-time on the emerging feedback from the CQC and working with our teams to make sure the action plan is really robust and embedded. And in fact, in our session later on, the board will be discussing the detail of the action plan to make sure you're comfortable with the approach. We've got 4 key work streams, which you've got outlined on page 12. Compassionate culture, regulatory compliance, some infrastructure issues to support staff being heard, and risk management and board delivery. And I think we're all committed, I know we're all committed to continuing to move at pace to deliver these actions. So really important. We're not fully cited on the CQC timeline. We believe the report might be in the process, which means publication around early November, but we're not certain because we've had a number of time delays. So in the meantime, we've already agreed that we will press on as a board and we will make sure that the issues that we are aware of are being taken really seriously and taken forward. So just to note that, and our work with Good Governance Institute around risk management and risk management systems will start soon. We have a board and senior leadership workshop in October to look at those areas and make sure that we have got it right in terms of escalation of risk to board. Just a couple of good news issues. You'll note we've signed a memorandum of understanding with the university around health research, which is really positive and will really strengthen our partnership around research. We've also had really positive feedback to our individual placement service following their fidelity review, which is their inspection, and they've been assessed as good. Following our assessment, we have been reconfirmed as Cyber Essentials Plus, which is a great achievement and not as easy to get as it sounds, really difficult to achieve. And so well done to the IT team. And the Trust ECT team have been awarded a national award around excellent patient, the best patient experience was the title of the report. So really positive. That's the ECT team. A service that's often not talked about particularly publicly, but is very important to some of our patients, and the team have done a great job there. Just to report that the Eliminating Dormitories project continues and the Worcestershire wards are now complete. Some of us have had the pleasure of a tour of the new Athlone ward, which is looking fantastic. Really good to see a significantly improved environment for patients. So that's really positive. The work in Hereford is not yet complete, but ongoing and will complete next year. But equally, the work that is complete so far in Hereford is looking fantastic and really improving the environment for patients. And finally, just to note, Jamie's term of office coming to an end. Mark has already mentioned this, but on behalf of the exec team as well, Jamie, I just want to thank you for your huge commitment, and particularly to the Mental Health Collaborative, because you have been an absolute champion driving that forward and really believing in the potential that partnership working could really enhance mental health and well-being in our communities. So thank you for that. Mark will confirm in due course when NHS England have confirmed Jamie's successor. And a strange one to end on, but the board are aware that I've announced my retirement, planning my retirement in April 2024. So it's just noted in the report that the process is underway to appoint my successor. Apologies, Mark, there was quite a lot in there that was important to draw out, but thank you for your time.
Thank you, sir. No apologies needed. There was some quite important stuff in there. Jamie, then Janet, please.
Thanks, Sarah. I wanted to ask about the major conditions strategy, the national document. I don't normally find Department of Health national documents particularly helpful, but I was quite intrigued by this one. So I dug it out from the internet and had a look through it, and it seemed to be, I might have got this wrong, but it seemed to be quite important, actually, important opportunities for how we might, and indeed the system might, look at doing things differently around personalised care, much along the lines we heard from Jane and her experience at Evesham this morning, but also around greater integration between physical and mental health services and how we support the attempts to improve lifestyles. And I just wondered, Sarah, what you thought was the best way for us as a trust and us as a system to use this to start asking some of those questions. You know, how is it going to inform what we do and not just become one of the cliched strategies that sit on a shelf?
No, I think it's quite important, Jamie. It's interesting because we were expecting a refresh of the national long-term plan for the NHS, and particularly around mental health. But this seems to almost have taken over to a degree those conversations. And I've been invited to a national meeting around the mental health element because obviously, as you'll know, mental health is one of the conditions that's included in the strategy. So that I think will be really interesting. Obviously, on the timeline, I can't from memory. Matthew or Sue might remember the timeline for the consultation on this, but my thoughts were that it would inform our strategy refresh, which is due next year. I think the timing of this process will fit in line with that. So any emerging thinking, new initiatives and conversations can inform our strategy as we refresh it next year would be my initial thoughts. But I don't know if exec colleagues want to add anything. No. Okay.
Okay, Janet and then Martin.
Yeah, thank you, Sarah. A lot in that report. My question was about the flu vaccinations. I was interested to know about our timescales for that and getting them up and running. But equally, in the past, we've always had a target percentage that we've had to achieve. And I just wondered whether that was the same this year and what our planning was like around that.
I'll ask Natalie to step in as she's the expert on this topic.
Yeah, thanks, Janet. So flu, we're planning to commence the beginning of October. We're taking a slightly different approach this year, but pretty much going back to what we've done pre-COVID, which is really using lots of local vaccinators to do drop-in clinics, floor walking. The COVID vaccine is very difficult to transport and move around. The flu vaccine isn't. It's really easy to move around. It's a single dose. So it enables us to take that much more flexible approach, which we know will increase and maximise uptake. Lots of people are ambivalent around vaccines, so they'll have it if it's there, but they might not go and deliberately find one. So we'll offer that range of ways to access your vaccine this year. And we are still obviously waiting for the vaccine to arrive, but that is planned for the beginning of October. We, as always, have a sequin target for the national vaccination. We will aim for as many vaccines as we possibly can. That's the ultimate aim. It's about protecting our staff and our patients. So as high as we can possibly get. And I think for me, it's really important that we don't focus on it being a sequin target, but we focus on it being the right thing to do around minimising infections and maximising everyone's health and well-being. And that's a really important message that I've been giving out to our local flu champions.
Thanks, Natalie. Martin.
Well, I had my invitation from my GP actually about 20 minutes ago for my COVID and flu vaccine. I just wanted to pick up, not surprisingly, where Jamie was going around the national conditions strategy, because it's something dear to my heart, and actually the sort of stuff that we're doing with the Staten Island group in New York, bringing them over in 2 weeks' time. But I just wanted, it requires a fundamentally different approach to be taken around data, incentives, social determinants of healthcare, that will take more than a little while to implement, and the sooner we can get on with it, I think the better, because I think it's where healthcare is going, and I think we shouldn't really wait for a strategy refresh to get our thinking sorted on how we move down that journey, because we want to be at the front end, not the back end, given our primary care and out of hospital care focus.
Thanks, Martin. I don't see anybody else showing, so I don't think there's anybody else. Thank you, Sarah, for that report. And with regard to vaccinations, I noticed a number of board members already put in the chat that they got their vaccinations booked. And I think, in the absence of anything else, we may very well have a vaccinator, local champion, come along to our next get-together, maybe in October, because this is one of those areas where I know board is foursquare behind trying to encourage staff and show leadership in this area. So for those of us that haven't got it in any other way, one of Natalie's staff may very well be available at our next board meeting to make sure that we are leading on that front. Okay, thank you very much indeed. If we move along then to the board assurance framework, and before I hand over to Jill for this one, I'll just remind board that we are around risk management and all aspects of risk and how we deal with this as an organisation and as a board. In fact, we are to receive an external review in this area in the next few months. So I don't propose to go any great detail of discussion now on the board assurance framework, for that very reason, is that we're going to have an external examination that's going to inform us of where we are, and then I suspect we will be far better placed as a board to have those discussions. So with that caveat, Jill.
Yes, I was just going to say that we've had quite a lot of discussions in the executive team and with operational staff and corporate staff about how we identify, score and escalate risks across the organisation. And I think a lot of our focus has been, have we got the right risks that are escalating? And so when we look at the papers that you've got on Diligent, for example, the ongoing top risks at 59, from looking at that, whilst there's obviously a number of risks there that you would expect to see, there's possibly also some that have not reached that level. And so that's going to be one of the very significant areas of focus going forward. What you've got in the paper are the summary of the top risks as they're currently scored by the risk owners, as well as the board assurance framework. And also we look at the spread of the papers that we're bringing to board and how they're linked into the risks on our BAF, because one of the discussions that we've been having and we're hoping to improve going forward is whether we are bringing the right papers to board to ensure that board is best placed to have a good oversight and manage risk in the organisation properly. And the board assurance framework is there with the amendments that have been made. But as Mark says, we've got some an external review and an external support with Good Governance Institute, who have quite a history of work in this area that is currently ongoing. And we are planning, I've been having discussions about planning the October half-day session, which is a joint session between board and senior leadership team, very much with the focus of identification, escalation and scoring of risks and responsibility at different levels in the organisation, and whether people are really clear about what their responsibilities are and how risk management can actually help them fulfil their roles. And so that is work that is ongoing, and we will be spending half a day at October's board development. We're also, as part of that, building on an earlier session that we had with Good Governance Institute at board. I'm going to be identifying a small task and finish group with Mark to actually look at risk appetite, to again how we better use that And I will be speaking to Mark about who needs to be on that, but I would immediately think that Martin, as chair of audit committee, and probably at least a clinical executive will be on that, and possibly another Ned as well from chairing one of the other committees. Given the comments that we've made about the reviews undertaken and the further work, I wasn't intending to provide any more information about this report, but very happy to take questions, although some of the risk questions I might have to defer to executive colleagues for risks in their area.
Thank you, Jill. Jamie.
Thank you. Mark, just to clarify, are you saying in light of the forthcoming review, you're not too keen for there to be much discussion about the detail of this now? Because I had a question about one of the risks.
Jamie, I would never stop you asking a question. You know that full well, but that was so yes, I will take that. But what I'm suggesting is there's likely to be substantial change around this whole document and how we deal with risk. So I didn't want to get us into too much detail on that aspect, but if you've got a question, absolutely ask it, because it might be very pertinent to assist us, so please do so.
Well, thank you. It's concerning 1334, the disruption of food supply, and this was discussed briefly at Finance and Performance, and I just wanted to check, I guess with Robert, two things. It seems a very low risk of likelihood when we know that we're actually dealing with this at the moment. It's already happened and we're already dealing with the consequences. So that seemed very low. And the more substantial point I wanted to ask about, it refers again, as it did at Finance and Performance, to the risks to patients with food allergies because of the change in supply or the temporary supplier and their difficulty in providing allergen-free foods and specific diet for patients. So I wanted some information. I don't know whether it be from Robert or from Natalie, how we're dealing with that on the wards to minimise the risk to patients from this.
Yeah, I'll pick that up. So we had the discussion, or part of the discussion, at F&P committee, as you referred to earlier, Jamie. This is the risk that went to that committee, and subsequently we need to update it slightly for what we're doing. So what you recall from the committee is that we've actually got quite a manual process in place with spreadsheets and monitoring and tracking that we're setting up with the suppliers to mitigate against the any potential for harm to patients. That's actually probably the main driver of the risk here in terms of the impact and the consequence that's having on the service in terms of all that need for putting in the manual intervention. That's kind of the discussion we were having at F&P. So the impact is mitigated in that way, as we discussed. We do need to update the risk, which we are doing, to reflect that the impact is more around the knock-on impact to the team and what that's doing around capacity, because we're having to mitigate against the potential for the wrong food going to patients.
Okay, thanks.
And Sarah, you're going to add something?
I know Jill's mentioned that we're going to do a complete review of this, so don't want to go into too much detail, but just one on the BAF. The risk around the ICS, I think, probably does need refreshing, because it feels quite out of date now, because it talks about a lack of partnership working, but there are some risks within that are probably relevant to Martin's comments on the strategy around whether we've got sufficient sort of population data, etc., to inform decision making. But I just suggest we review that one if the board are happy, so that we can update that while we also do the parallel conversation about looking at our overall processes.
Yeah, I agree. Thank you, Sarah, especially as I think the ICS/B has just received its first, I don't know what the terminology is, but NHS England, was it, come in and grade how we're doing as a system, and broadly speaking, without the right terminology, we're doing okay in the grand scheme of things, and so I think that would be useful for a review. If there's nothing else, the only other point I was going to make on this, Jill, if I may, from the chair, is that sometimes we forget the word assurance in board assurance framework, and we tend to discuss the risks rightly so, on those risks and how we're mitigating them. But part of the role of the BAF is for a board to be able to clearly see and articulate as necessary how we take assurance that these risks are being mitigated, so they're not preventing us achieving our goals and aims. And it would be useful if in the review that you are commissioning externally, it'd be quite useful to ensure that that is a consideration within this, so it just doesn't become the corporate higher level risk register. It's actually about how we take assurance as well, if that's okay. Okay, thank you very much indeed. Next paper is, oh, sorry, but we do need to agree the BAF where it is actually. Can we all agree where it is with the caveats that we mentioned about the review? Yes, thank you very much indeed. The next paper, Sue, Strategy and Partnership. Before you embark on this, thank you very much for this paper. I can't, there you are. You've moved to top left, Sue. Thank you for this paper. This paper contains some real meaty stuff in terms of our activities as a trust and some of our areas of improvement and indeed on occasions problems. So thank you for the paper. It's a developing paper, I know, but it's sort of getting there, I think. So over to you. Thank you.
Yes, thank you, Mark. And yeah, these are the 6 priorities that we agreed last October. And at our next development session in October, we will be reviewing the priorities as we move forward to 24-25. As you say, there's a lot of detail, which I'm not going to go through. I'll assume that everybody's read that. But you can see we've got some really important moves in performance in some areas. I think we'd all see the changes to the targets around talking therapies and the transformation that's undertaken there. And we know that things like the children and young people services, we've done some internal work, but we still have a wider transformation piece and we need to scope that out. And that will probably be one of our priorities for 24-25. Just to remind board that the PMO oversees all of the work programmes. This is the 6 that we at board look at, and F&P will look through all of the programmes of work through the broader report that goes through that committee. The only piece I probably wanted to just flag is that priority 4, where we talk about the improving the clinical model for adult mental health inpatient services, says there about the draft options appraisal ready in September. We just need to remember that is very early work, so in actual fact they wouldn't be coming out into the system and further review until there's been further work in that area, and that's actually scheduled for January. So John can put more information if board members want to know more, but I didn't want people to feel that there was something that they needed to see, because actually it's very early stages. And so no more, I wasn't going to pick up any more detail really, and just open up to board for questions and to colleagues to add in depending on what those questions might be. Thank you.
We can't let you get away that easily, Sue. There we are. I didn't think we would. Martin.
Thanks, Sue. It's not explicitly said, unless I can I've missed it, but the link between 4 and 5 are pretty critical in terms of how we do the GIRFT around mental health and then in the community, and getting that seamless flow through, but also the link with physical health and that sort of thing. Can we assure that those are absolutely aligned, taking into account those two? They're not moving as separate programmes.
Pass over to John and Matthew to add on, but the whole piece around the community mental health transformation is clearly now we are a year in with the final phasing to become embedded into our system. That's actually undertaking a whole review now anyway, and some of that actually goes back into what is the voluntary sector providing, and have we got that really nested into district collaboratives, primary care network delivery models. So it is seeing that whole pathway, Martin, but obviously from an operational point of view we're trying to get as much cross-fertilisation and shared data sets to make sure that we are seeing that capacity in the round, so that the bed base is dependent on community capacity and vice versa. So Matthew, you're involved with both programmes. I know whether you want to comment further.
I guess all I would say is that the associate directors for both STUs continuously working together in this space. We've just commenced a review of patients who've been admitted from community adult mental health teams and tracking back the root causes of their deterioration and omission, with a view to making further improvements in community team provision.
I'm just thinking, Matthew, in terms of, if we heard this morning, the links between Evesham Community Hospital and the community teams, cycling around of people, are those sort of things being taken into consideration when we're looking at community teams and mental inpatient wards to get that connectivity going much better than it perhaps is at the moment?
Yes, absolutely. I mean, it's one of the main issues we're discussing at this point in the model development. So we've also got a work stream undergoing at the moment, which is looking at how we improve things like allocation of care coordinators for patients who weren't previously known, who were admitted to hospital, timeframes that should happen in, and also how community mental health teams in-reach into hospital wards when people are admitted, so that we can overcome any barriers to their discharge and make sure that care continues well from inpatient out into the community.
John, did you wish to add to that point, or is it separate?
Yes, same point actually. Just to add to what Matthew's just said, from the GIRFT piece of work, which is mostly focusing on inpatient, I think the general approach we are taking is that the inpatient services, acute and rehab, are seen to be complementing, and it's just the tip of the iceberg of a much bigger community service. So that's always in our mind. And also in terms of the design of the work streams that are developing the clinical pathways, the outcome measures, and the operational machinery, we have people who work in community services as well as part of that, so that we have those pathways quite streamlined. So very much the focus is not just on horizontal integration between inpatient services, but vertical integration, not just with community and primary, but also with higher secure care going the other way as well.
Thanks, John. Jamie.
Thanks. Not sure whether this is one for you, Sue or Matthew, but it's on the Children's Transformation update. A year ago for FNP, we had a discussion about the embryonic Children's Transformation programme and how it should interface with wider partnership work. And it was explained that this wasn't going to be a fundamental rethink of children's services. It was our particular part of it, but nonetheless, other key players like Worcestershire Children's First and Herefordshire County Council were going to be part of a transformation board. It was obviously going to be difficult to do something in isolation from those with statutory responsibilities for children. But a year later, the update shows it's a problem. So I suppose the question is, well, this was foreseen right at the start, and we had taken the steps to involve all our partners around the table in our transformation board. So I suppose the question is, how are we going to deal with this? If there are issues to do with our proposed transformation fitting in with wider system-wide changes, and I don't just mean the health system, but the wider children's system, we had anticipated that. It's still a problem. How are we going to make sure these things are properly integrated?
So Jamie, as you point out, we've been working over the past year with our partners. So we've been undertaking internal operational improvements and having ongoing discussions with our partners around the table. So representatives from Worcestershire County Council, so Worcestershire Children's First, and the ICB and the voluntary sector have been sat around the table with us as we work through our internal processes. They're aware, and we've had discussions about what the next phase looks like, and the kind of areas we wish to tackle. And the ICB and Worcestershire Children's First are very much in alignment with us. So they're very happy to work with us on developing proposals for what the future of the health component of children's services in Worcestershire looks like, and how their parts will seamlessly work together with that. I think we've seen some progress around these discussions, even in our discussions at Mental Health Collaborative. So we've had the discussion earlier in the year about the mental health investment standards priorities, and we made the agreement that there were some gaps in children's services community provision at the tier 2 level, and we made the agreement in the collaborative that should be a major area for investment. So I think there are some positive signs from partners that there is commitment to working together and working together on the same agenda. So between now and kind of end of October, we're starting to work up proposals ourselves internally and with partners about what phase 2 of the programme is going to look like and how we're going to work together for a wider system transformation as well.
But Matthew, the reason I asked the question is because the report gives the impression that this interface is challenging and something of a problem. But the way you've described it is it feels more kind of business as usual. It's all okay.
Well, I don't think anybody would pretend that this is easy, but I think we are in a space because of the work that we've done over the past year. And a piece of work like the balance work as well, that we work together with partners to redesign therapy services across Worcestershire as well. Because of the work that we've done together over the past year, I think we're on the same page. We're on the page that says, look, the challenges for providing increasingly complex levels of healthcare and social care and education to children and families with increasing levels of need, that's a big challenge for all of us, and we're not going to meet that challenge unless we work together. So the commitment there is that, you know, we will work together. We recognise the same problems. We're not saying it's going to be easy. I guess we're saying we've got to a place where we're kind of on the starting grid together, and we've got that commitment to work together to develop kind of phase 2 of the transformation.
Okay, thanks. Thank you.
And Tessa.
Thank you, Mark. I'm just reflecting on the recruitment and retention priority, and I think Elaine and the non-executive directors that are on Workforce Committee would share with me their frustration around the pace of progress against this priority. I know Martin shared with a member of Elaine's team some suggested contacts outside of the trust where other organisations are making speedier progress and particularly using ESR data differently. And I just wonder whether there is something here about perhaps not seeing this just as an OD and HR issue, but actually looking at how other members of the exec team and perhaps Sue's strategy and partnership focus or lens on that might actually help us pick up the pace on some of the issues we're having around both getting effective data around recruitment and retention, but also changes that we could be making internally to the systems and processes that would speed things up. So I just wanted to flag that I think there's maybe a trick that we're missing here that we need to pick up on and move forward more rapidly.
I think everybody agrees, Tessa. Nobody would disagree that when it comes to recruitment, then any pace and improvements would always be welcome. Thank you. Final point from myself then, Sue or whomever in the executive. Jamie picked up a lot on the children's side of things. Sarah and I attended the ICB yesterday and heard a deep dive, ICB board meeting, heard a deep dive into children's services. There was to be 2 questions from me, but they're on the same theme, which is system engagement, because I know the children's side, so I'll leave that. You've answered that, Matthew. But the virtual wards are a key component of the system's desire to improve across the piece. I can read the words in the report, Sue, but can somebody give me a more subjective judgment about how the introduction of the virtual wards are happening across the trust and how successful they are, and the potential for rollout to assist colleagues in the acute trust and indeed give better care to patients. I don't know who that would be.
Well, it would be Rob Cunningham, wouldn't it? And I think we're on an urgent care call out, aren't we? So I don't know, Matthew, whether you've got more information, put some context in via Rob.
Yes, I mean, I can give certainly an overview. As you're aware, we commenced a pilot of the virtual ward project in Wyre Forest. Our initial aim would be to roll that out more comprehensively across Worcestershire as funding became available. I have to say we're at the point where we're still in discussions with system partners about how funding will be released to us to undertake that additional work.
Okay, I recognise my timing could have been better. Rob, for those who weren't aware, Rob had to go to a system industrial action meeting at 5 to 10. That was all pre-organised. So, okay, it's one of those ones that I think it's not only fundamental to us and our patients, but across the system. So how we are being successful or otherwise in that area and how we roll out and improve is a key aspect of what we do. Okay, thank you, folks. If there's nothing else on that, Sue, thank you for that report. And we look forward to having the discussion in October about what of those elements need refreshing and what comes out, what comes in, and probably more difficult, what drops out, if at all anything. Thank you. Hillcrest, another issue that's been going on a long time that received a report. Thank you very much. Matthew, I think this one's yours, yes?
It is, thank you. Apologies first of all for some of the formatting that's been caused by transfer to diligence. You've got some odd pages with just one thing on. Sorry about that. It's what happens when you move from one document format to another. Just for note as well, this is a BAF item, so it's covered under failure to achieve the triple aim outcome, and Hillcrest is specifically mentioned in that BAF item. It's also on the risk register under workforce. The initial risk scoring is 15, but it's been mitigated down to 12 with action. So that's why it doesn't show currently as a board level risk. In terms of the paper, I'm drawing your attention to the following points. The Hillcrest Improvement Plan, it's substantially completed now, and we're proposing a formal closing out report to come to Q&S in November. In terms of recruitment, some recent improvements. I'll qualify that and talk about that a little bit more. Got a new deputy ward manager in place, a new band 6 OT, 3 newly qualified registered nurses have joined, and one more return to practice nurse is joining next month. Some of the outworking of that, so some of the difference that you can see that's already making, is that we've got a full activity program running on Hillcrest now. So patients are involved in meaningful therapeutic activities every day, and there's been really good engagement. So if you go to the wall, that's exactly what you see happening. We've had strong healthcare support worker recruitment through the CSWD pipeline. So we've got 3 that have come on. We've got potential for 3 more coming on, all of whom are actually keen to come and work at Hillcrest. So this is the qualifying bit, I guess. Although there's some encouraging signs around permanent staffing improving, I'd say, look, note carefully, the new joiners that we've got only take us to the level that we were at in August 2022. So even as we go into October with the new registered nurses coming on board, we're still at over 50% registered nurse vacancies. We asked the leadership team on Hillcrest to undertake a review of the quality risks of opening up to 14 beds, because we're operating at 10 beds at the moment. Their view was, until we've got qualified staff, permanent qualified staff at a higher level, and they're sufficiently embedded and we're confident that we can maintain quality, then we want to continue operating at 10 beds. And that's a decision the executive are supporting. Just to note, the on-site advocacy work has commenced now, so the very good work of using a specific group of VCSE partners to come in and work with patients about understanding their experience and understanding the improvements we can make from that. That started last month, and we get our feedback, our initial feedback from on-site advocacy on the 29th of December. So they're producing their first report. We've talked to patients. This is what we've found. On block booked agencies, so obviously I've mentioned that we've got a large number of vacancies, and we've been using 2 agencies to have what in other trusts are called long line staff. So staff who just work with us but don't work for us. So I say, look, there's a mixed picture of success there as well. So on the positive side, the fill rate has been strong, minimal use of off framework on Hillcrest Ward, and we've had good continuity of staff. So we've used far fewer staff than we did when we were using agencies on a non-block book basis. There have been challenges to quality of staffing though. So 5 staff overall have had to leave us. 2 of them have been discontinued by us, and 3 have left because what we were expecting of them didn't match their expectations of the workplace. So we're glad that those people have moved on. We meet with the agency weekly at the moment, the main agency Care 24, just to kind of keep going through our expectations of staffing and make sure that those staff that aren't meeting expectations are on a plan to improve. We've put on additional training, so we've put on training around care planning, risk assessment, and that kind of thing. We've got we've also had, some new recruitment. So we work with the agency to bring on people who specifically want to work with us in this way. We've got a more detailed paper coming to Workforce Committee in November, which will actually address some of these points around the quality concerns and the positives of block booking. So that will go into it in a bit more detail. In light of the vacancy position, though, we've made an executive decision to continue block booking arrangements through to March 2024. Our belief is that's the best way at the moment to secure the kind of continuity of staffing that we need. We've still got the substitute bed capacity going on at T. Grosvenor in Wrexham. It's used well with patient and family agreements. So for somebody to go up there, they need to agree that they're going to go to Wrexham. We help families with transport arrangements, and we have weekly in-person quality visits there from our trust as well. There's some issues emerging about the availability of patients for transfer, which I've detailed a little bit in the paper. So we've had some underutilisation of capacity there. So we've had a couple of beds not used all of the time over the past couple of weeks. I've got a meeting next week to develop further proposals to meet those challenges. So do we look at widening the patient group? Do we look at how we use inappropriate out of area transfers to move up to T. Grosvenor? So a number of issues we need to work through, and then we need a proposal back to local authority partners, because these detained patients, that has an implication for approved mental health professionals as well. So in light of the decision to continue restricting the capacity on Hillcrest to 10 beds, our current plan is to continue arrangements with T. Grosvenor at least through to, well, initially through to March 2024. It doesn't contractually obligate us to them, but they need notice to pre-book the bedded capacity for us, a reasonable notice. Just a reminder as well about the limitations on Hillcrest as a building. So it's an old-fashioned design. You wouldn't design a mental health ward like this anymore. It's got a lot of blind spots, got a lot of long corridors, and it's got a lot of rooms that don't lend themselves well to natural movement and observation. It's also an isolated unit, so it's cut off from other immediate support from mental health wards around it. Following a discussion at JNCC, we've begun staff engagement. So a discussion with staff beginning to seek their views about their preferences in the light of re-provision of Hillcrest function at an alternative site. So we started the discussions to say, look, if in the future we decided that we would not be using Hillcrest because of the challenges with the unit, what would that mean for you as a staff member, and how would you like to work with us? You know, would you like to move to another site? Would you like another part of the job? Is this going to be difficult for you if you live a very long way away from, say, Worcester, and you're a Redditch resident, or you live in Birmingham or Warwickshire? The outputs of those discussions will inform the development of a proposal which Sue is working up for suitable public engagement. So talking about timescales and a detailed plan which will be informed by the availability of staffing. So one of the considerations we will have at the end of this is if we have very few staff whose preference is to come and work in Worcestershire, I think we have to assume that differences in timescales and planning will be required if we're looking at alternative provision. So in conclusion, I hope the board will confirm their support of the following executive decisions: that bedded capacity at Hillcrest will not be extended above 10 until we've got permanent qualified staffing levels improved, that agency booking arrangements will continue, and that substitute bedded capacity arrangements should continue as well. And a reminder that in November, our proposal currently is that Trust Board would receive a proposal for preferred options for acute adult inpatient provision and timelines for the achievement of that. We've rated the paper conservatively, I would say at level 5, which is say comprehensive actions are agreed upon to address causes of performance concerns, with the evidence of delivery of all of the majority of agreed actions, but with little or no evidence of the achievement of outcomes.
Thank you, Matthew.
Thank you.
Can I suggest we take the 3 non-executive directors' questions, because I'm guessing Matthew would be the respondee to those. So I'd take Martin, Tessa, and Janet's question, and then Matthew to respond to them on block, please. So if we could do it that way, Martin.
Yep, thanks, Mark. Matthew, just picking up on top of page 93, diligent, you refer to the fact that AMPs won't travel to Wrexham to carry out, and that impacts on our CTO, people starting CTOs. How does that? How do we comply with our least restrictive practice if we are delaying CTOs, and what's our mitigation associated with that, because we can't continue with AMPs not travelling to Wrexham unless we've got some other way. And the second one, there's no mention, and it may be because it's not an issue, but there's no issue around the mental health access to mental health hearings by people being in Wrexham, etc. And can we get assurance that that is not that is not the case? Thanks.
I was going to ask the same question as Martin about the access to hearings for the patients up north, but I also wanted to just make a comment that when we saw a version of this workforce committee, I think it was last time, and when I looked at the data, I thought that the actual likelihood of recruiting to sufficient capacity was slim to non-existent. I mean, increasing capacity by 2% over 2 or 3 months, it's going to take us literally years to get anywhere close to the right capacity for staffing. I appreciate that the decisions that you're going to be bringing, the paper for the options that you're going to be bringing to board in November may well change the requirement around staffing capacity, Matthew, but I suppose I'm just making the comment that we made at Workforce Committee that the pace of this is a concern, and the need for block booking agency with the challenges that has about quality and consistency and so on is a real concern, and I think is a significant risk both for staff and for patients.
Thanks, Janet. Finally, sorry, Tessa, finally, Janet, then we'll go back to Matthew.
Yeah, thank you. Yeah, I suppose I'm building along what the lines of Tessa's question, really, because I was reflecting that actually we've got a team here that's, you know, we've still got vacancies, we've still got agency staff, there are some issues with the agency staff, and then putting on top of that, we're putting in a major sort of change consultation around people actually moving elsewhere. And I'm just reflecting that actually might, well, I think it will impact on the ability to recruit staff, because who's going to go and work somewhere where actually they may end up working somewhere else. So it was around, I think the pace is really important, because else I think we're going to start to leach staff and agency workers as a result of the change. So I think I would, it's one of those things where I think, yes, we need to engage and we need to do that, but we need to do it quickly and get this sorted. So I suppose I don't know if that's a question or not, but then my other question or comment was going to be around on page 87 of Diligent. There's a comment about execs continuing to meet the Hillcrest team at least every 2 months. And I'm thinking, actually, in my mind, I think that should be at least every 2 weeks, just to keep tabs on what's happening and get the feedback from people and show that actually we're still, we are interested and concerned about what's happening. So just a couple of sort of anxieties, I think.
Thank you, Janet. So, Matthew, looking for some assurance around remoteness from us in relation to hearings, AMPs, some reassurance around recruitment, agency block booking and risks there, especially in relation to the consultation, how that may spook the staff, so to speak, and then some reassurance around exec engagement in this process.
Yeah, okay. So first of all, around the AMPs not travelling to Wrexham, I mean, how we've been addressing this is conveying the patient back to base wards for AMPs to engage and assess at that point. So we've actually transferred the patient back and then started the CTO. That probably has caused a slight delay in the commencement of CTO, which is a reasonable argument to say that is against Mental Health Act principles of least restrictive setting, because that the delays have been short, typically a few days, but yes, that's a delay. I would say that a delay is endemic in having patients placed outside of county anyway. The decision pathway is always extended. It's a challenge. We've spoken to both local authorities. They are. There's a further challenge that comes with the placement being in Wales, because AMPs in England cannot legally transfer any of their responsibilities to AMPs in Wales. So you can transfer between Welsh internal local authorities and England local internal authorities. So if this was in Staffordshire, an AMP from Staffordshire could undertake some of the duties on behalf of, but that's not possible because of the cross-county thing. So we're doing it by transferring the patients. Access to hearing, that hasn't come up as an issue so far, but again, we would convey the patient back locally to access a hearing locally. I can provide you with a more detailed answer because I'm actually sure that that's built into our quality framework, but I don't have that to hand. So I'll provide a detailed post-board answer to that. In terms of increasing the staffing capacity on Hillcrest, yes, I agree. We're probably into a few years of building capacity on our inpatient wards until we achieve the right levels. If you look at it, our vacancy rates across inpatient wards, we're very, very much the same as other mental health trusts across the Midlands and across England. This is a recruitment challenge for all of us. I believe that some of the ways in which we're tackling this at the moment are probably among best practice in any case. So developing a block booked agency arrangement with a trusted partner and trying to develop long line staff is one thing we're doing. We have had improvements in bank fill recently. So if you look at our bank fill over the past year, actually that's going again in the right direction. We've got new people joining our bank and we're starting to yield some results from that. We have actually been able to reduce the block booking slightly as a result of bringing staff on, which is good. And as a result of that, we've released block book staff into the availability, and we've booked some of those for Mortimer Ward, where we're having similar things. So actually, some of this becomes a bit of a virtuous circle. And as we develop our relationships with the agencies, yes, there's a cost involved in this, but we're starting to get an agreement with those agencies about how those staff work with us, and actually that we've got staff in the block booking that actually we're very pleased with now to partner with. Something that's helping immensely as well is the value added by our healthcare support workers. You know, we've had 6 new healthcare support workers working on Hillcrest. You know, and I have to say that they're absolutely delightful in the fresh attitude and engagement that they've brought. You know, that they're helping set a new culture on the ward. But we're in this for the long haul. So yes, I'd reflect this is going to take a long time. But we can only put in those mitigations that reflect national best practice, I guess. In terms of Janet's question about we're not commencing staff consultation. This is engagement at the moment, and the reason that we're engaging before starting anything formal is we really need to take a temperature check to understand the consequences of any consultation issue which we might want to raise. Yeah. So one of the things that we're testing is, okay, if there is very low supported staff wanting to go forward to a new location, we're going to have to really think about how we do that safely and well. Yeah. So before we put a consultation proposal to our staff, we want to understand very well what that means. That's exactly why we're doing it in that order. That started, those conversations have begun. They began last month. We're hoping to wrap them up, in fact, within the next week or so. We want to reach everybody and get a consensus about how people feel before there's a consultation question even put forward. So that's why we've done it like that. And just to I guess for assurance, executive engagement isn't limited to meeting with the leadership team. That's an additional thing. So the meetings that we have are kind of semi-formal meetings where we're all the execs involved are together with that leadership team and unpacking issues in a more structured way. We're all keeping very close links with the ward. The schedule of visiting is more often than you might expect, and we're engaging frequently with all levels of leadership on the ward as well. So that's not the only thing we're doing. We're engaging a lot more. In fact, I've got a meeting this afternoon to discuss aspects of Hillcrest ward staffing and particular issues as well. So it's something that we're continuously involved in.
Thank you. Sue and then Martin.
Yeah, as Matthew's outlined some of the staff engagement, I thought it might be helpful to just give board some headlines around the broader stakeholder and public engagement. So I've been working very closely with colleagues in the ICB, most notably Richard Keeble, and yesterday we met with our NHS England colleagues. At the moment, we are wanting to take the contents of where we are and what Matthew's just outlined to the Health Overview and Scrutiny Committee on the 11th of October. You may recall that Natalie, myself and Gemma went to talk about Hillcrest to HOSC back in February. They were requesting an update anyway, and clearly they had flagged there the limitation of the building and the impact that was going to have potentially on turning the handle on increasing the workforce numbers. And as you say, you know, we're not making the progress we would all want to. So we would like to go to HOSC and start to talk about what the change options are, what we can do at pace, and then to start going out and having a number of listening events, just to make sure that we understand what impacts there may well be, and as boards start to think about how we mitigate and put plans in to reduce and action some of those issues that may well be raised. So those will go across November. So you've started to see now, I suppose, more tangible actions about we're not where we need to be. We need to be heading for something more sustainable. We need to do the early conversations with the staff. We need to be doing the early conversations with stakeholders and the public. So Matthew and I are sort of working hand in glove over the next few months to make sure that we're really clear on the sequencing of where we go next. So I can provide more updates, but just wanted board to know that at the moment, the next date will be HOSC in October.
Thanks, Jill. We'll bring this one to a close with Martin.
Yeah, thanks. I just wanted to pick up on where Matthew, in terms of the AMPs and the CTO issue. Jill, is there any difference? Because I think there is a significant difference when we've got out of area treatments because we have an emergency bed gap, whereas we are here planning to put 5 beds out of area without access to AMP, and therefore there's a planned delay in potential CTO take up. Where does that leave us with Mental Health Act?
I mean, as Matthew said, one of the underlying principles of the Mental Health Act is the least restrictive approach should always be adopted. And if we are moving from somebody being an inpatient to going on a CTO, they're obviously then going to be in the community, albeit still subject to the Mental Health Act. But it's a matter of fact and degree. I think inevitably in these situations, if we're talking about a delay of a very short period of time, a matter of days, then actually I don't think it creates a legal problem for us. If we were talking about something that was building in delays of weeks and weeks or something like that, I think that would create a very different problem for us. I don't understand that is the problem here. And of course, it may well be that patients do have the right to independent review of their cases at certain points in their journey, whether that be through the appropriate hospital managers. So in this case, the appropriate hospital managers are the local managers in Wrexham, or through the judicial route of the tribunal. And so that there is that access there if patients were unhappy, and everybody who is detained under the Mental Health Act does also have access to an independent mental health advocate, as well as this is one of the few areas for which legal aid is automatically available for patients to have access to appropriately qualified solicitors to challenge any aspect of their detention. And I can confirm that we haven't had any solicitors or any legal issues being raised about the impact of patients being placed in Wrexham.
Thank you, Jill. And Matthew, thank you for bringing the report forward, because I know it was a request of board to make sure you came back and kept us topped up on this issue for the obvious reasons. So thank you for doing that. and I think we continue to need it as well for two reasons. One, there's a substantive issue of Hillcrest staffing and everything else, because we know it's not the optimum setting for a mental health inpatient unit, as you suggested, so we need to be aware. But there's also hopefully some learning that we can take from what has happened in Hillcrest over the past couple of years, bring that through to, I know John's doing the GIRF work around this as well, and so I think it's important that we keep this on the radar, so thank you very much. Okay, before we have a 10-minute break, if I could ask Elaine now we got a quick position statement on the quality strategy. Elaine.
Oh, thanks, Mark. Hopefully you'll have enough time to have that break a few minutes earlier. This is for information. We have an opportunity, we still do have an EDI strategy, but we've got an opportunity to reaffirm it and to refresh it totally. So that's what we're doing at the moment. It gives us an opportunity to refocus our trust strategy, our trust values, to look at how we'll make clearer accountabilities for staff, encourage shared ownership, and also be clearly articulating to our staff what happens if things aren't going as well as they could. So this is essentially outlining where we are at the moment, what's going to happen, and where we intend to be by November in order to bring the strategy back. I think a couple of notes I would say is that it's an iterative process. Whilst we may have a strategy, I think it's important that we continue to go back to it by way of ensuring that we're learning and refining it as we go along. What's going to happen next is we have a series of engagement events, because that's probably the main piece in this, internally and externally. So we're looking to pull together, we have some dates in the diary already, a range of staff from across the trust, but we're also going externally and engaging with some of our VCSE colleagues and Health Watch, etc. around this. A key part of that is ensuring that we have some really clear metrics and measurables in terms of what success looks like, but how we're moving the dial around our commitment to ED&I as an organisation. So myself and Sami Boatema-Cook are leading on that. Our intention is that we bring this back in November with a view that we're able to sign that off and continue to progress it. So that's all I wanted to say, but I'm happy to take any questions. It was just to provide some information to board and assure you that we are making progress.
Thank you, Elaine. I can't see anybody indicating, so just one point from me rather than the question is, I know that one of our strands of our emerging plan in reaction to the initial feedback from the CQC is leadership and EDI. I assume that our work in there will inform this strategy, won't it? So a little concern in my mind is it might be too quick to bring back a finalised thing by November, because as you indicated, it is iterative, isn't it? And just to be mindful that that substantial push we're going to have on this agenda over the next 2-3 months to make sure we capture that and don't react too quickly. I'm not saying we're going to.
I would agree. I was a little hesitant. November, is that too soon? But I think we will have made substantial progress to provide an increased level of assurance to board that we're heading in the right direction. So November is not necessarily a very hard stop, but to increase the assurance to board.
And I know some of you may wish to make a note that I've just asked to be aware of. Perhaps we need less pace. I know that's that's something that is not often heard from my position, but it was a concern that we get it right rather than lack of pace. John.
Yeah, no, thank you.
Thank you, Mark. Elaine, I really welcome this position statement, and I note particularly that we are very ambitious in that we have not just stopped at equality, but looking at equity as well. And also, this is not just about our staff, but also about our patients. So quite an ambitious scope, and my view would be very similar to Marcus. Also, how are you going to get the kind of patient perspective into this, the clinical perspective, not just from an organizational development perspective, if you see what I mean?
Yeah. So I'm linking in with one of our NEDs, Carol Camino, who is quite well known in the VCSE sector, and we're going to be looking at. I've already spoken to some of our community organisations like Health Watch. Sammy's contacting them directly to ensure that they're represented at these consultation events. It's about sharing the strategy with them, getting a view from them, particularly in the space of what the metrics need to look like from their perspective. So we're looking at a number of ways we can do that, and that means doing some of that consultation outside of our 9 to 5s as well. So we're being quite broad in the how we do that, and also working with our staff networks. So I attended staff network meeting yesterday and saying to them, I'd like to see them being represented at all of these consultations events and getting their views, because it needs to be owned internally, but it also needs to be creating a clear expectation externally as well. But I do take the point. It is ambitious. We want to make it as meaningful as possible and not just a tick box activity.
Thank you, Elaine, and thank you, everybody. Can I just ask Elaine on that one, as apart from the chair, the NED lead on EDI, if you could keep me bolted into the progress on that, I'd be obliged. Thank you very much indeed. Okay, folks, thank you, Elaine. You were as succinct as you promised. Can I suggest, colleagues, we've been going for nearly 2 hours now. If we have a break until 10 past 11, it'll allow you to recharge glasses and get your eyes away from a screen. Okay, I'll see you all at 10 past 11. Thank you.